welcome everyone to our final Lunch Learn Link seminar of this academic year. We have a Cigarette Restitution Fund awardee, Anna Beavis, and we're happy to showcase some of her work. But I just wanted to let you know, the audience, that this is being recorded and you may request or find our recordings on the Cancer Prevention and Control website at the Cancer Center. So just search on that, you'll get there. So I'm so happy to have you with us today. Dr. Ann Rothich is going to introduce our speaker.
Yeah, thanks, Norma, and welcome everyone. I apologize, I have a bad cold, so I'm going to keep my video off and spare you guys. But I wouldn't miss today because I am really happy to introduce Dr. Anna Beavis. She's a GYN oncologist here at Hopkins. She's also an amazing clinician scientist, and I'm extremely biased because she is a mentee of mine and she is a great, great colleague of mine. Anna did her fellowship here at Hopkins, and her fellowship, or her thesis fellowship, focused on cervical cancer care disparities here within the Hopkins system and in the Baltimore area. During that time, she also did her MPH here at Bloomberg under my mentorship from the other GYN oncology faculty. She had an extremely successful capstone that was published and got lots of publicity, focusing on adjusting cervical cancer mortality rates at the national level for hysterectomy. And then it was no surprise, but I was extremely delighted that she was hired on as faculty. And she was supported early in her time here under the Birch. And I think she'll touch on some of the work that she did in endometrial cancer through her Birch, but she broadly does really great research focused on gynecological cancer disparities. Her and I worked together on a P30 focused on HPV vaccine hesitancy. She's also PI on an American Cancer Society Award, looking at how we can address care disparities through social resource needs screening, and she has several other pending grants. And I think today what she's going to present on is a really exciting topic, and it's certainly one that she has persisted with, which we will have a chance to talk a little bit about at the end, but I think is really just a credit to her ability to sort of keep pushing through and pivoting and really ending up with research that's super important. And I know it will continue to grow. So with that, I'm going to pass it over to Anna to give her talk today on endometrial cancer and obesity. Anna?
Great, thank you. Take 30 seconds to set it up so that hopefully I can see my slides, share my screen, and see you guys. But I definitely can't guarantee that I'll be able to do all of those things because even though the pandemic's 2 years in, I have not mastered Zoom. Let's see. Let's go there. Okay, can you see my slides?
Yep.
Fantastic. Okay, thank you for that very warm introduction. I think I feel very lucky to have done my MPH and have met Anne and some of the other like Norma and Elizabeth over at the School of Public Health, because I think that's really helped my career as a clinician scientist. It's really easy to get bogged down in the clinical, and having that connection between the School of Public Health across Wolf Street has always been great and really helped there. So the only disclosure I have is that I have sat on an advisory board for Ethicon. So today there's kind of three main things I wanted to talk about. The first two are really getting everyone up to speed on what endometrial cancer is and how it relates to obesity. The second, the recent trends that we're seeing in endometrial cancer, why that's important. And the third is this role of early detection and prevention, which is something that, as Anne mentioned, I have persisted on and I think is becoming increasingly more well recognized as an important topic, both for research and for guideline changing. So obesity has been an epidemic for a long time. We know that, since the 1980s, we have gotten progressively as a society larger and larger. And the pandemic has only worsened that. So as you can see here from these headlines, we have just generally more obesity. We're seeing more childhood obesity. And women in particular do seem to be at higher risk than men, particularly in the age group that I am concerned about for endometrial cancer, which are the perimenopausal women. Here, I think it's always nice to go back and look at these trends. You can see back in the 1990s, fewer than 20% of people in almost all states were obese. And now in the year 2000, 2010, we see huge increases. And this is our most recent map from 2020. I mean, there's a huge number of states that have an obesity prevalence of more than 40%, and the majority of states are at least 30%. It's also important to recognize when we talk later about obesity and cancer, that obesity is very much, the prevalence is differential by race. So this is non-Hispanic Asian adults, as you can see, very low rates of obesity. These are non-Hispanic white adults that have pretty significant prevalence of obesity, but not as much as those Hispanic adults, and also non-Hispanic Black adults who have the most obesity. So one caveat being that, obesity is typically measured by BMI, and that is not a comprehensive measure of obesity, but it is the easiest that we can do. So there's some caveats here. BMI is by no means a perfect measure and is definitely beyond the scope of this talk today. So we know that cancer is associated with overweight and obesity, and increasingly this has definitely been recognized in the last years to decades. There are 13 cancers that are known to be associated with excess weight, so either overweight or obesity. And then the 5 that I've put in boxes here are the strongest relationship and kind of both the highest magnitude as well as the strongest relationship that's been shown. So renal cell, postmenopausal breast cancer, of note, not premenopausal breast cancer, gallbladder cancer, colorectal cancer, and uterine cancer, which is what we're going to talk about today. As a GYN oncologist, this is what I do all day, every day. I literally just left a room where I consented someone for surgery for this exact cancer from this exact exposure. You can see on the right-hand side that the hazard ratio for developing any obesity-related cancer goes up with the years exposed to overweight and obesity. And so it's not just, are you obese or overweight now? It's actually how much time are you exposed to this, which is kind of like pack years of smoking. And I think all the studies that have looked at this, I think are really, really cool and interesting because it suggests, lower duration has lower risk. Here, I picked out 3 of the cancers that are often discussed when we're talking about obesity. So colorectal cancer, you can see a strong relationship developing that with years of overweight and obesity. Postmenopausal breast cancer as well, although it's not, that duration doesn't have quite the same effect. And then I really want to draw your attention to endometrial, which is the lining of the uterus. I mean, that is one of the strongest relationships that you're going to see. And I think that endometrial cancer is very, very clearly the most obesity sensitive cancer of all of the obesity related cancers. I'd also note that the population attributable risk, which I've put below each of the figures, you can see about colorectal cancer, about 5% is attributable to overweight and obesity. Postmenopausal breast is about 10%. But for endometrial, we are estimating somewhere between 50 and 58% of all new cases are secondary to overweight and obesity. So this is definitely somewhere we could potentially intervene. We also have to all get on the same page about our language and anatomy. And this is something that can get quite confusing when you start looking at national studies. So I wanted to clarify that the uterus is made up of the myometrium and the endometrium. The endometrium I've highlighted here in red, it's the lining of the uterus. And when you get cancer in the lining of the uterus, it's called a carcinoma. When you have cancer in the muscle of the uterus, which is the surrounding smooth muscle tissue around the endometrium, that's what cramps when you have cramps or contracts when you have a baby. Those cells will produce a sarcoma. And so uterine cancer, if you were to go to SEER, for example, and try and look at trends, if you just looked at cancer of the uterus, you would have been including both sarcoma and carcinoma. And so that's just an important point when we look at some of these trends. They're not all equal to each other. However, endometrial cancer is much, much, much more common and makes up a much larger proportion of these cases than sarcoma does. There's also two types of endometrial cancer, and I'm not going to get into huge detail here, but to highlight that type 1 is the most common, up to 90% of cases. It tends to be slow growing, which is good because it has a better survival. It presents at an earlier stage, but that is the cancer that's most associated with obesity and unopposed estrogen, which we'll talk about. Type 2 cancers, unfortunately, are much more commonly diagnosed in women of Black race, but those women are often not obese, and it is less clear exactly the carcinogenesis and the risk factors that lead to that diagnosis. Fortunately, those cancers are much less common, only 10 to 20% of endometrial cancers. So for this talk, we're talking about obesity, so it's going to be about this type 1 endometrial cancer. There are many different biological mechanisms that have been studied to decide, how does obesity cause cancer? And can we really say that it's a cause, or is it just an association? I think the last 10 to 20 decades or 10 to 20 years of research have really shown really well done studies showing clear, at least biological mechanisms. So the ones that have been proposed most commonly are an elevated insulin growth factor 1, which is a protein that can stimulate cellular growth, chronic inflammation, which is you can measure levels of inflammation in obese versus non-obese people, and you will see more inflammation in those who are obese. Adipokines like leptin, which can be higher, those can change cell signaling pathways, increase the risk of cellular proliferation, which ultimately, when that becomes dysregulated, is how you end up with cancer. There's some suggestion that the microbiome in an overweight or obese patient may be different. That could be contributing, and microbiome research is becoming much more prevalent, and I think we'll be learning more about this in the years to come. And then the major biological mechanism, especially for endometrial cancer, is going to be the production of sex steroids, which I'm going to talk about on the next slide. I also think it's really important to note that there's some psychosocial associations that can lead to lower rates of screening. Women who are obese are much less likely to want to come to their GYN appointment. They feel more stigmatized. And so any kind of screening, including cervical cancer screening, these women may actually present at later stages because of that psychosocial impact on their ability to access care. So I mentioned sex steroids. So for type 1 endometrial cancers, these ones that are driven by estrogen, we have to think about the lining of the uterus, which is the endometrium. And I promise this is as much kind of basic science as we're going to get into in this talk. But estrogen at the level of the lining of the uterus, which is what I'm kind of showing here in this typical menstrual cycle, estrogen is going to encourage growth of those cells. So you get more and more cells produced, hyperplasia essentially, and then progesterone comes along during the luteal phase of the cycle and regulates and organizes all of those cells, and then you have a period where everything comes out of the uterus and you start again. So if you only have estrogen, or you have lots and lots of estrogen, but you don't have a lot of progesterone counteracting that, the lining will just continue to grow and grow and grow in an unregulated way. And eventually that will form hyperplasia, which is, dysregulated growth and excess numbers of cells. And then they will become atypical, meaning abnormal. And then they will become cancerous, meaning able to invade and metastasize. So many different mechanisms will increase the estrogen level in a patient. One of those is just not ovulating. So if you don't ovulate, you don't have a period, and therefore you don't have the regular monthly progesterone counterbalancing the estrogen. Patients who have polycystic ovary syndrome, who are perimenopausal, who are obese, may have anovulation or not well-regulated ovulation, and so they'll have more estrogen to progesterone ratio, and then the lining will grow thicker. If you have, you're young when you start your period, or you go through menopause at a later age, you're exposed to more estrogen over your lifetime. If you never have a pregnancy, then you don't get the progesterone effect during that pregnancy, and that can increase the stimulation of the lining of the uterus. And then adipose cells specifically have a hormone aromatase, an enzyme aromatase. And aromatase will take your normal steroids like androstenedione, for example, that are just circulating in your blood doing what they do, and turn it into estrogen. And so that is why we see those really impressive curves between exposure to overweight and obesity and the risk of developing endometrial cancer. It's those elevated estrogen levels from the fat cells primarily. And then lastly, iatrogenic estrogens. So when people take hormone replacement therapy, if they have a uterus, they need progesterone and estrogen. If you only do estrogen or some of the bioidentical estrogens where the levels are kind of unclear, that increases the risk that lining will grow, become hyperplastic, and then become cancerous. So I would argue that we have a lot of evidence that obesity can cause endometrial cancer. The strength of the relationship is very strong. It's consistent. There's hundreds of studies showing it. We have studies showing that the exposure before, so the temporal relationship, obesity before does increase the risk of endometrial cancer. There's a clear dose response relationship, which I'll show you in some of the work we've been doing. And then we have a very nice biological plausibility mechanism. So that's kind of the background on obesity and endometrial cancer. And I think your big takeaways are that a huge amount of endometrial cancer is due to obesity. And we have clear mechanisms as to why. So next, I wanted to talk about the recent trends in endometrial cancer incidence and mortality, because as you might imagine, we have now had more and more years of being obese since the obesity epidemic began somewhere in the 1980s, 1990s. So increasingly, more and more women are at risk, and not surprisingly, we are going to see an increase in incidence and mortality of this cancer. So about 66,000 women are diagnosed each year in the US. As a side note, as a GYN oncologist, even someone who's 50-50 research, I probably do an endometrial cancer case every week, if not 2 a week. They're incredibly common because this cancer affects so many women. About 13,000 women will die each year from endometrial cancer. And we know that since the 1990s, there's been a steady increase in cases in all age groups. As mentioned earlier, when I did my work at the MPH, my capstone, we corrected cervical cancer incidence or mortality rates for hysterectomy. And it's really important to do that when you're looking, especially at racial differences for endometrial cancer as well. And that's because the distribution of who undergoes a hysterectomy is differential by race. And non-Hispanic Black women undergo significantly more hysterectomies at younger ages because of other things like fibroids and abnormal bleeding, and such that if you don't correct for the hysterectomy, the differential distribution of hysterectomies, you end up with a denominator that doesn't really represent the women at risk. And so I put this slide in here because I really like, you can see the uncorrected endometrial cancer rates in the A on the left, and then on the right, the B figure, you can see there that the red line, the dark red line, those are non-Hispanic Black women. And you can see the incidence exceeds that of non-Hispanic white women, which is important to recognize because up until around 2007, that was not the case. And this was actually, I remember in medical school being told that this was a cancer of white women. The risk factor was being white, and that's no longer true. It's also important to note, although outside the scope of going into any detail in this talk, but I feel that I have to make note of the fact that the type 1 cancers you see here on the left, much more common in non-Hispanic white patients, but the really aggressive ones I told you that would present at a later stage and have a lower survival rate are much, much more common in non-Hispanic Black women, which you can see here in these hysterectomy corrected incidence rates. The US, not surprisingly, is leading the way in uterine cancer. This is a recent study which demonstrated that Northern America has the highest incidence of uterine cancer and one of the higher mortality rates. as well. We're also seeing, and I apologize because I guess my animation there didn't move that little box away, but what you can see through that box is prevalence of obesity on the left, and then the incidence of type 1 endometrial cancer on the right. So as you can see on the left-hand side, we have various different lines, all representing different ages of women. And that's looking at obesity and how it's changed over time. And where I would draw your attention to is this gray line, which is women 55 to 64 years old, as well as the orange line here, which are the 45 to 54-year-old women. And those are the women that are right around the highest risk of endometrial cancer, which has an average age around 63, although we'll talk about how that's changing too in a second. So on the right, the incidence of type 1 endometrial cancer, the gray is women over 55, the orange is 45 to 54, and the blue is those under the age of 45. And I think it's really important that you can see that in all of these, it's increasing, but we're actually seeing a steadily and measurable increase, even in women under the age of 45, which is where a lot of my research interests lie, and I'll talk about later. Depending on the study you read, and the more recent studies show higher percentages, but about 13% of cases of endometrial cancer are now diagnosed in women who are premenopausal. This is from the same study. They looked at the mean age at diagnosis, and that's gone anywhere from somewhere around 64 to 65 and is now down around 61. I think they did a really nice job of making this graph look very dramatic. It's only really a 3 or 4 year difference, but I think it is a great graphical representation of the fact that we know we're seeing more endometrial cancer cases and we have more younger women exposed to lots of obesity. So the average age is decreasing. You know, we wouldn't expect to see this huge decrease because age is still a risk factor for endometrial cancer. But the fact that you are able to demonstrate this multi-year difference in average age of diagnosis over just 2 decades speaks to the, I think, the true urgency and the kind of impending, what I perceive to be explosion of cases that we will see as women age into the 40s, 50s, 60s after a lifetime of obesity. We are also seeing an increase in mortality. So this was a really nice study just published last month that got all of us as GYN oncologists really took our attention. So the black line shows you ovarian cancer mortality, and the red line shows you uterine cancer mortality. So essentially, we have finally started to make some headway in ovarian cancer mortality. It is decreasing. We have had a number of new drugs and things like that. We're not doing any better at screening, but we have definitely developed new drugs that are helping women live longer, etc. So ovary cancer, which was previously the most, had the highest mortality rate, responsible for the most deaths, is now becoming more survivable. Whereas you can see that endometrial cancer is less. That line is rising and they're almost touching. And so this really caught all of our attention, and I think will definitely open up, especially funders, to the recognition that even though previously we know about the survival from endometrial cancer is quite good, it is getting worse and we are seeing more cases. And so we really need to focus our attention on this cancer. And on the right, they just have I think a nice representation of the mortality rate ratio of uterine to ovary, where you can really see basically since 2005, that huge change. So to summarize what we've kind of talked about so far, incidence is increasing, mortality is increasing, more and younger women are diagnosed each year with endometrial cancer. We know that the majority of these cases are due to obesity, but we don't really know who or how we would screen for cancer. And that's really where we're going to focus the last section, which is this role for early detection and prevention. And this is something that Dr. Rossiter, Anna, and I have been working on, and I'm really passionate about. I think ever since as a med student, I diagnosed a patient with about 400 pounds, came in with bleeding. We diagnosed her with endometrial cancer, and she underwent a hysterectomy a few weeks later, and she was 29 years old. And that case has stuck with me because it's preventable. And I think that we can do a better job, and we can do better, for these patients through early detection and prevention. So I've been building a team, mostly Anne Rossich and myself have then, gotten some other collaborators from the clinical side and the epidemiology side, all people who are passionate about this. So Amanda Fader is a GYN oncologist over at Hopkins as well, who has a strong interest in endometrial cancer. And then Batel Blechter was a Bloomberg PhD student who has graduated and now is at the National Cancer Institute and is still helping us with some of our research. So one of the questions I think that often comes up is like, well, can we prevent an obesity-driven cancer? Because we know from many studies that it is very hard for people to lose weight. And I very naively, as a medical student, thought that if I told obese women that their obesity put them at risk for cancer, that would magically enable them to lose weight. And that just is not how being overweight and obese works. It's not how we can help people. So one thing I want to point out before we talk about early detection is that we don't have to have people lose weight in order to prevent these cancers. For example, a progesterone IUD can reduce their risk by up to 60%, and we actually can use those to treat cancer as well. Depending on the study, the progesterone-containing contraceptives will also reduce the risk by somewhere around 40%. Bariatric surgery reduces the risk purely by weight loss. And there was a very interesting study using, I think that was the Women's Health Initiative, that found that in postmenopausal women who had at least a 10% intentional weight loss, a 10-pound intentional weight loss, which is actually not a huge number, they had a 40% reduction in risk of developing endometrial cancer. So we don't have to have people lose weight in order to help prevent these cancers, but that does help. The other thing to know is, what are the symptoms? They're actually quite simple, and they are bleeding. So in a postmenopausal woman, they will often recognize that they should no longer be having periods. And so if it's been several years and they suddenly start spotting or bleeding, then they will present to their doctor. And in most cases, it will be caught early because of that sentinel symptom. In premenopausal women, the symptoms are the same in that it's abnormal bleeding, and we call abnormal uterine bleeding, or AUB. However, for premenopausal women, they often don't know if it's abnormal. They could have a polyp, they could have fibroids. These are benign things that could be causing their symptoms, or it could be cancer. And this is where a lot of my research has tried to focus, is how we figure out, how do we get the right people to a biopsy early to figure out if their abnormal bleeding is cancer or not. So you can diagnose this in an in-office procedure. It's a biopsy that takes about 5 minutes. For some people, it can be uncomfortable and they need to have what's called a D&C, or a curettage, basically a scraping of the lining of the uterus under anesthesia. But in the vast majority of patients, a simple 5-minute in-office biopsy procedure can diagnose the cancer or rule it out. Oftentimes, people will ask me about ultrasound and whether or not we can use that to help triage patients, because an ultrasound is less invasive than a biopsy. But the reality is that ultrasound is useful in postmenopausal women, but it's so non-sensitive and non-specific in premenopausal women that it often provides very little help and may be falsely reassuring. For the treatment of endometrial cancer, I wanted to just put this in to get us all on the same page to understand, how do we treat these cancers? So the first thing when I see a patient is I determine how old they are and if they are interested in future fertility. And if a patient is over the age of 45 or they're not interested in fertility, then the standard of care recommendation is hysterectomy. If they are interested in fertility, and I have some patients who come in, let's say 35 years old, with polycystic ovary syndrome and obesity, and they've just been diagnosed. For those patients, still the standard of care would be a hysterectomy. However, we can try other treatments, recognizing that that is not the standard of care and that it could potentially allow the cancer to spread while treating it. So that treatment is a progesterone therapy of some kind, and the IUD I use the most commonly because it's simple and in some studies might work better than the pill. About 65% of people who you treat with progesterone are going to have a complete response and then attempt pregnancy, and about 1 in 4 of those will actually be able to achieve pregnancy. So it's not ideal. And as I said, it does allow the cancer to potentially progress. About 35% of people just won't respond to the IUD or progesterone, and they'll ultimately need a hysterectomy. And even patients who ultimately undergo pregnancy and have a delivery, they will also need a hysterectomy. The response rates for hyperplasia, which is the precancerous state, which has the same symptoms as endometrial cancer, are about 90%. So if we can either detect the cancer early or ideally prevent it by detecting the endometrial hyperplasia, then we could do a lot better for these patients and potentially avoid a hysterectomy and avoid the stress of all of this. Additionally, when you perform a hysterectomy in a young woman, especially if you need to remove the ovaries, which do produce estrogen and therefore can stimulate cancer, you will put that patient into premature menopause, which has significant symptoms, hot flashes, vaginal dryness, decreased quality of life, cognitive issues, as well as increasing the risk of cardiovascular death, their increased risk of overall mortality in general, as well as their increased risk of osteoporosis. So if we can avoid hysterectomy, that would be ideal for these women. And I think that through early detection and prevention, we should be able to. So I often get asked, well, why are we not screening for endometrial hyperplasia or cancer? It is not recommended. And that is because unless you have a high genetic risk, so a patient with Lynch syndrome, for example, would be recommended to undergo a biopsy every 1 to 2 years from around the age of 30. But if you don't have that high genetic risk, then the risk is not felt to be high enough. And I think that is problematic because it doesn't stratify by other risk factors. And the other argument against this is that the survival from endometrial cancer is so good. So the 5-year overall survival for a type 1 endometrial cancer patient, all comers, is about 80%. If you're diagnosed in stage 1, it's about 90 to 95%. And that is very good. And so if you only look at mortality, screening doesn't make as much sense as if you were to use a different outcome. Excuse me. So we don't really screen for endometrial hyperplasia or cancer yet, but in a patient who presents with symptoms, what we would do is a biopsy, like we talked about earlier, and that's about 90 to 95% sensitive. So pretty good. However, who we should biopsy and when is very much a point of debate. Here I've put 3 different guidelines from the US, Canada, and the UK. And they recommend in a woman who's premenopausal, who has abnormal bleeding, they would undergo a biopsy based on their age. And you can see there's age 45 or 40, depending on the guidelines. But if they're younger than those age limits, and in the US, that's age 45, then you're just supposed to take into account their risk factors. And those could be anything, but primarily focusing on obesity, unopposed estrogen, polycystic ovary syndrome, and anovulation. You can see on the right that in the UK, they do not biopsy any woman under the age of 45 until they basically have at least 6 months of symptoms, or they say fail medical management, fail progesterone. So these guidelines, to me, are insufficiently precise. And this is what our research has really focused on, because when I sit in a room with a patient with abnormal bleeding, I did not have any guidelines to help me say, well, this woman with a BMI of 30 should definitely get a biopsy, and this woman with a BMI of 50 should or shouldn't. I mean, obviously the higher BMI likely should more, but we didn't have numbers. So additionally, almost 50% of women who are going to present to us with these symptoms are obese already. So if you just biopsy everyone based on obesity, you're just going to biopsy everyone who will, well, at least half of the patients who walk through the door. And while this is a short procedure, it can incur anxiety, pain. I mean, it's something that we wouldn't want someone to undergo unless they needed to. It's certainly not a pap smear. I always am sure to tell patients, you know, it's more than a pap smear. It's going to be more uncomfortable than that. Additionally, obese women often report abnormal uterine bleeding. So about 50% of patients presenting to bariatric surgery have some kind of abnormal bleeding. Most are unaware that they have this higher risk of hyperplasia or cancer, but most who undergo bariatric surgery or are presenting for consultation for bariatric surgery have recently had screening, kind of in demonstrating that they're engaged in care. So we wanted to better define who should undergo a biopsy. So in those women who are 45 years or under, can we better define like who should undergo a biopsy for abnormal bleeding? So this was a project that I worked on with Anne Rossett, shown here, and Batel Bletcher, shown here. And it's near and dear to my heart. We've been working on it for a long time, and I'm going to show you some of the results, which are not yet published, but are being submitted in manuscript form in the next month, which I'm very excited about. So we basically did a retrospective cohort study looking at women between the ages of 18 and 45 who had abnormal uterine bleeding and then had some kind of endometrial sampling, like a biopsy or a D&C, somewhere in the Hopkins enterprise system, which is 5 different hospitals plus a community physician system. And we did this over a 3.5-year time period. We built risk prediction models to look at the magnitude of risk with various risk factors on having prevalent hyperplasia or cancer, because if you can detect the hyperplasia, that is ideal, right, for prevention. And then we calculated the incidence of hyperplasia or cancer stratified by the key risk factors we identified in the risk prediction model. And then we developed some prediction probability tools to potentially help providers make these decisions. This cohort of women ended up being 3,175 women who underwent a biopsy with an average age of 39. 40% were white, 40% were Black. So we actually had quite a bit of racial diversity reflective of our population here. About 50% of patients had a BMI that was consistent with obesity. And I think importantly, we had over 140 women with a BMI in the highest classification, above 50. That's very rare for a study. Here you can see in our risk factor analysis, we actually found that non-Hispanic Black women had a lower risk of having prevalent hyperplasia or cancer. I will just mention that in these young women, mostly what we're detecting are the precursors to type 1 endometrial cancer, which we know is less common in Black women. And then, as I will discuss at the end, we don't have any data for women who didn't undergo a biopsy. So there's some bias in the, who would be included in this study, as it is retrospective. You can also see a very clear dose-response relationship between BMI and the relative risk of having hyperplasia or cancer, all the way up to a BMI of 50 or greater, increasing the risk by 8 times. PCOS, or polycystic ovary syndrome, also had an independent effect, an effect that was independent of BMI, of about 3 times higher. This shows stratified by the BMI and also by race, the relationship between obesity, the level of obesity, and prevalent hyperplasia or cancer. And you can see non-Hispanic white in the first kind of 5 bars here, clear dose response relationship, non-Hispanic Black, clear dose response relationship, though the magnitude is lower. Hispanic and other, also a very clear dose response relationship. And we really wanted to think about, what are some benchmarks at which we would consider doing biopsies for these women. And if you think about, let's say a 5% risk would lead you to do a biopsy, then all women with a BMI above 30 would qualify. Whereas if it was 10%, for example, you would potentially be just in certain racial and ethnic groups using the highest BMIs. I will note, and this is one of the things we need to work on, is we don't have a benchmark. There's no number or percent risk at which we would recommend a biopsy, because this work just hasn't been done yet. This is just an example of one of our predicted probability tables. And our hope is that when we publish this, it will be something that providers could potentially use to say, okay, my patient is Hispanic, her BMI is 40, and then in this particular table, it's patients with PCOS, but without diabetes. And so they could go down and estimate their risk is probably somewhere in that 20% range. So this study, I thought, really was great because it showed a wide range of prevalence estimates of hyperplasia and cancer within a group. So even though I didn't show this, was about 2.6% of, or 4% of people had hyperplasia or cancer. But when we stratified, we had these huge ranges, anywhere from less than 1% to 35%, depending on the group you looked at. We also provided these estimates by those factors that the rates differed by, which most studies that have been published similar to this don't look at race, ethnicity, and don't often even look at BMI. And we're hoping that this tool that we've created could potentially be used for shared decision-making. We did use claims-based data though for this, so it's not a perfect study, it's retrospective. And then as I mentioned, only women with abnormal bleeding whose physician determined they should have a biopsy could be included, because the women who didn't, we didn't have biopsy results of. And then we didn't account for other causes like fibroids. As I mentioned, there's no consensus level of risk, which is actually the next thing that I wanted to try and assess. So this was work with Anne Rossich and Amanda Fader. We worked on surveying obese and overweight women and getting their perspectives on undergoing a biopsy. And my big question was, at what % risk threshold would a woman want to undergo a biopsy? Because as I showed you, there's these wide ranges of risk, and a physician may have an idea of like what would lead them to recommend a biopsy. But I think, especially if we're talking about a screening or diagnostic tool, you really need the patient's input as well, particularly when it's such a sensitive and potentially uncomfortable procedure. And then I also wanted to know what factors influence that decision. How do they make those decisions? So we surveyed this 359 women through using MyChart recruitment through Epic, and all women were overweight or obese. We found that about half of them did not know that obesity increased their endometrial cancer risk. This is not uncommon. That number is actually a little bit better than it was several years ago in a prior study that I did. And then we also found, similar to some other studies, that about 42% of premenopausal women had abnormal bleeding. Most women wanted a biopsy if their risk of endometrial hyperplasia or cancer right now was 1%. And we use something called a modified standard gamble to give them various different levels of risk until they reached the threshold at which they would want to undergo a biopsy. And beyond the scope of what I'm talking about today, we did describe the procedure and use cognitive interviews to make sure they were understandable, both from a medical standpoint, but also from a layperson standpoint. We found that women were most influenced by their perceived risk of endometrial cancer, less so by procedural risks. They interestingly cited that their own weight was only a big factor in about 40% of patients, though their perceived risk of cancer was a big factor in about 70% of patients. And things, logistics like time, were really not anything significantly concerning for the patients when determining if they would want to undergo a biopsy. So I was surprised by that risk threshold of 1%, because if that would be most people in our other study where we looked at their risk of having hyperplasia or cancer. So what is the future of endometrial cancer screening? So right now we are not screening because the mortality rate is low, but I would argue that incidence and mortality are rising. More and younger women are affected by endometrial cancer. It not only affects their fertility potentially, but it will also affect their overall cardiovascular health and potentially longevity. So really, is mortality the right outcome for considering screening? And we really need to better define these risk benchmarks, and we can see that patients will take a very low level of risk and potentially want to undergo a procedure. But is that really cost effective? Is that the reasonable thing to do? The endometrial biopsy really does have several of the characteristics we consider good for a screening test. It has a detectable precursor. It has high sensitivity. We have an intervention. You can do an IUD, progesterone, weight loss. There's things we can do if we detect it or detect it early. And it's an in-office, quite cheap procedure. So what we really don't know is who and when we should screen. So from the data that I presented to you today, we've shown you kind of the immediate risk. So if a woman's sitting in front of me, I can tell her, based on your characteristics, the risk of you having prevalent hyperplasia or cancer is this, but we don't know what happens in the future. And that's something that Dr. Rosic and I are working on, getting data so that we can look at risk prediction models for future risk, modeling that exposure to obesity over time. And importantly, stratifying that by race and ethnicity, which most studies have been unable to do. And honestly, most studies have looked at postmenopausal, non-Hispanic white women. There's a huge gap in the literature of racial and ethnic diversity in this. We also hope to evaluate and validate the current model that we've created that could potentially help guide clinical practice. So, do our risk or do our prevalence estimates, are they similar in other similarly stratified populations in a population other than Johns Hopkins? We're looking to get patient and provider perspectives on this, to develop acceptable tools that would help providers at the bedside make more precise estimates of who would have highest risk and improve early detection, and then help incorporate those risk benchmarks into guidelines. So thank you for listening to my long talk about endometrial cancer and obesity. I think this is really going to become so much more important in the next few years and decades to come. And I know that the NIH is increasingly recognizing its importance. I'd like to thank Anne Rosic primarily as my mentor, collaborator, life coach, everything person. I have known her now, I think it's 6+ years, and it's been just a wonderful relationship. So thank you. And then everyone else here, my other research team members, the Maryland Cigarette Restitution Fund, and the Birch for their funding for this research. Thank you.
So Anne, would you like to guide the discussion? I saw your hand up.
I think I was clapping, but maybe I hit the wrong one.
Yes,
Yeah, absolutely. I would sort of encourage everyone to, if they have any questions, to please put that in the chat. But I will start off with just a question, because Anna, you touched on it. But I wondered if you could sort of talk more about sort of the issue of infertility, because we saw that being raised sort of both going into the risk that women who haven't had children or maybe are not able to have children can contribute to the risk, but also as sort of an important outcome. So can you just sort of talk about that, and how as a clinician you're taking that into account, and also maybe the impact that this is going to have on sort of the needs for infertility treatment in the future?
Yeah, that's a great question. There's so many details that I could go off into all the little tangents on. And I think this is a really important one that is like basically the center of many of the discussions that we have with patients. First, we know that obesity itself is associated with infertility. Infertility is also associated with endometrial hyperplasia and cancer, and the temporality of that sometimes gets confused. But the obesity itself being a risk factor for infertility actually makes it so that even when we are able to treat these patients with progesterone, most of them will need some kind of assisted reproductive technology in order to conceive. And so when I meet a patient who may want fertility preservation for hyperplasia or cancer, they're immediately referred for reproductive endocrinology and infertility consultation, because we need to know their kind of baseline level of infertility, their likelihood of being able to conceive, because if, for example, that is very low, then delaying a cancer curing surgery, the risk benefit ratio kind of changes. So it both can increase their risk, and then once they're diagnosed with hyperplasia or cancer, can potentially becomes an important consideration in their treatment as well. Does that answer the question?
Yeah, absolutely. It sure does. And I'm just checking the chat sort of one more time. Okay, great. So I'll ask one more question, but I do want to sort of open it up to the floor. And Anna, I would just say one of the things, as you mentioned, that we are working on is to sort of overcome the limitations of the current data set, it being prevalent in a single institution. Can you talk about what has been done already in risk prediction modeling? Because it is something that we're looking to do, but there is sort of a history of that as well. How has that been done? Where has that been done? And why do we think that it sort of doesn't necessarily carry over to the United States?
Yeah, so I will say, caveat being the postmenopausal space, there has been there have been a number of studies that have used prospectively maintained data sets, like the Women's Health Initiative, the Nurses' Health Study, to look at this. But in the premenopausal space, which I think is really where the question lies, right? How can we best predict their risk, and therefore who would we recommend, screening in? There's really just been studies there's been a couple of studies. India has one, Italy has another, and many of them are just several hundred patients, and like several hundred patients under the age of 50. And then they develop these kind of elaborate risk prediction models with AUC curves and things that ROC curves with an AUC that really they're insufficiently, first off, their numbers are insufficient. We actually did not do ROC curves for ours specifically because we felt that when it was substratified, we just didn't have the numbers. And then also those countries have completely different exposures as far as obesity, the prevalence, or the incidence and the prevalence, how long they've been exposed. So there has not yet been a US study in the premenopausal population that's really addressed this. And I think that the differences, especially with the US leading the way in obesity, I think we can take their risk prediction, their prevalence estimates or their risk prediction and translate it to the US.
Great, thank you. I see a hand is raised. Thomas, do you want to go ahead and unmute yourself?
Yes, sure. So I was wondering if you are kind of aware of the emerging tests that are like Pap specimen based. I happen to be working on that for ovarian cancer, but there's the Pap gene test that out of Bert Vogelstein's lab that looked pretty good for endometrial cancer. I happen to work with methylation. There's a lot of work showing also that methylation can be used for diagnostics, but also probably for screening as well. And I'm wondering if that's, if you can comment on that at all.
Yeah, absolutely. I actually, as part of my Birch, was working with Bert Vogelstein on some of the patient kind of acceptability and feasibility side of that. I think so. Essentially, what his work does, which is it's incredible work that's very exciting, detecting DNA driver mutations of cancer in a Pap specimen. And what he has found is that really, in order to get that specimen and have sufficient specimen, at least for ovarian cancer, it requires what's called the towel brush. And the towel brush is essentially an endometrial biopsy instrument. And so I think that if that were to be considered from a patient perspective, it feels the same. It's an instrument that goes all the way into the uterus up to the top and then pulls out cells. And so if the gold standard is biopsy, I think that test in the future, we would have to see whether or not it would be better in some way than a biopsy itself. But I also don't know, and I know I've talked to him about this, is whether or not he can just use the Pap specimen for endometrial specifically. But because most of the data is being collected for endometrial and ovarian, they had switched to the towel brush. And as an active member of the GYN oncology team, I've done more Pap gene sample collections than I can remember. So we're actively trying to help get that data. But I think if we could add this to a Pap smear, like if you could take your just the brush that does the pap smear and detect DNA driver mutations in it, then, you know, from an epi perspective, we just have to tell them who to add this to on their pap smear for screening, and that would be amazing.
Great. Yeah. I mean, my understanding is that the PAP works well for endometrial, which is not for ovarian. Yeah.
Yeah. And that was, I did a very small little study looking at the pain differences if you were to just use the pap brush versus the biopsy as a way of showing what would be more acceptable to patients. And certainly the pain scores are much, much, much lower if you were just to use the brush. So if we could use that, I mean, women are having those every 3 to 5 years anyway. So I think it's very exciting as soon as we have enough kind of data to move forward with just the brush.
Great, thank you.
And Anna or Thomas, please remind me, is that hasn't been sort of used or validated for the hyperplasia, just for endometrial cancer, right? And so yeah.
That's correct.
That is correct.
And I'm doing similar studies with DNA methylation, which offers some advantages versus mutations. But yeah, we're mainly focused on ovarian, but we do plan on looking at this also for endometrial.
Yeah, and I think it's interesting. That's a really good point. What's really interesting is it's such a continuum from when you go from an abnormal cell to hyperplasia to cancer, that many of the mutations we would detect in cancer are actually also present in the hyperplasia, but many of them won't be. So that's it's a really good point. And I think it's really going to be very interesting to see if you can detect hyperplasia by just using DNA driver mutations, or if it, you know, waits and you're only detecting it at the cancer stage. I suspect you'll detect both.
Yeah, I think just not to carry on too much, but with the methylation, you might have a multi-analyte approach might give you better specificity for the different stages. As you go in, the mutations are going to, like you said, are going to be there probably pretty early on. Yeah, regardless. Yeah.
Great. It also relates to sort of our interest in sort of getting data where we can model that state separately, right? So thinking about all of these new technologies sort of coming on the line, and as we start to focus more on the hyperplasia state, also having really good data about who's at highest risk of that in case it's not sort of a universal screening approach. We do have one quick question. Anna, I will put it out to you, but obviously we have to keep it quick since we are running out of time rapidly. Norma asked, what are the prospects for weight loss interventions in any precancer or cancer patients who are obese? Yeah,
I mean, that's also something that, in addition to referring to infertility, it's really important to refer patients to weight loss interventions. So we have the healthy eating and weight loss program over at Green Spring Station, which is like a multidisciplinary approach to weight loss. And then we have bariatric surgery. Those are the two main resources that I will typically send. I will send every patient to the Green Spring Weight Loss Center, and then I will, in certain patients, discuss with them bariatric surgery, depending on their respectives, et cetera. But I think that it's a really important consideration. And we know from several small studies, but you can have hyperplasia or cancer, undergo bariatric surgery and have it disappear. Like, it's incredible. I mean, the numbers are small, they're all double-digit studies, but this is the proof of concept has been proven. And so I think what I, as a clinician, have learned is that it is insufficient to tell someone their cancer can go away with weight loss. Like, that's not enough. And so we really need effective weight loss partners to help patients with that part.
We do have one more question. We are not going to have time to get to it, but I will just put it out there, and you can follow up with Richard Roden offline, since he's asking questions, I think, coming back to the sort of earlier conversation about the ability to use ECC or tampons to capture samples for early detection instead of the towel brush or endometrial sampling. So again, looking at sort of other ways that we could get it. We do not have time for it, but I wanted to pass that along so that you guys had a chance to talk about it offline.
Great.
Norma?
Thank you so much, Anna, for this comprehensive talk. It was really a great overview and a systematic way of looking at, how can we address uterine cancer as a growing problem. So you fulfilled your title, and thank you so much. Bye-bye.
Thank you.
Everyone.
Thank you. Great talk.